And one of our health visitors, this young girl, she had to walk about almost 2 hours to reach his home. And he required dexamethasone and metoclopramide. And fortunately, there in the health post, they had injection dexamethasone and injection metoclopramide. And they had IV cannulas. They didn't have butterflies to, subcutaneous. So this girl put an IV cannula, taught the patient's son to give dexamethasone and metoclopramide every day. And, a week later, his headache was gone, his vomiting had stopped, and he lived for 2.5 months,
For today's episode, I am very pleased to welcome Professor Dr. Rajesh Gongal, who is Professor of Surgery at Patan Academy of Health Sciences in Kathmandu in Nepal. He served there as Medical Director and also later as Founding Dean and Vice Chancellor of the Medical School. After completing his fellowship and an MSc in palliative care from Belfast in Northern Ireland, he played a pivotal role in integrating palliative care and medical humanities in the undergraduate medical and nursing curriculum, later starting a postgraduate fellowship in palliative care, which runs at Patan. He's also the founding chairperson of Hospice Nepal, the first ever palliative care centre to be established. As founding president of Nepal's ambulance service and founding chair of primary trauma care in Nepal, Professor Gongal's career has impacted many areas of health. Welcome to Palliative Care Matters, Professor Gongal. Thank you for joining me.
Thank you for having me, Jane. Such a pleasure to be talking to you.
Can I ask you, first of all, what was it that interested you about palliative care? You have so many medical interests. How did you get involved in palliative care specifically?
When I came back from UK in 1998 after training in surgery for 7 years and then practicing surgery, so we used to deal with a lot of patients with cancer, and many of these patients had advanced malignancy where you could not do much surgically or even other adjuvant therapies. And these patients were discharged home without any support, and we found that they were coming back in a lot of pain, and there was not a lot of help and support for them. Hospitals were reluctant to admit them, and so we thought that something needs to be done in this area. And after trying to sort of establish something in hospitals, there was not a lot of positive support there. So we established our own non-government organization called Hospice Nepal in the year 2000. So after that, there's been no looking back, and it has really been a very enriching journey for us.
So did you do your training in Northern Ireland after that, after you'd completed the surgical and started Hospice Nepal?
So when we started hospice, we had very little training in palliative care, and we were just learning by doing and trying to take care of patients. And then in the year, I think it was in 2002, that Professor Max Watson, he had worked in Nepal for a long time, so he came to Nepal, and we went through a training in palliative care. So we got a lot of a lot of skills from there, and we just continued to provide palliative care as we started just learning by doing. And in the year 2015, I after completing my deanship in Patan, I decided to go for fellowship in palliative care, and I worked in Northern Ireland Hospice for 18 months there. So that really helped me improve my skills, and that also gave me the background for starting fellowship in palliative care back home.
That's very interesting, having worked in hospice in Northern Ireland and then taking those skills into what I imagine is a very different cultural setting and everything What are the major contrasts between those two settings, do you think? Particularly how advanced disease is approached, people talking about the diagnosis. Are there a lot of differences or similarities? How did you find it moving between
Oh
the
yes,
two?
a lot of differences, Jane. It's completely different. Here in Nepal, there's still a lot of family, close family culture.
Mm.
So there's a lot of decision making by the family, and conversations around death and dying is still very difficult. So a lot of denial. People do not want to talk about death and dying a lot. And a lot of times when we talk about cancer, we need first talk with the family, and then with their permission, we can talk with the patient. And many a times families would ask us not to reveal the diagnosis to patient, and that can sometimes make a lot of conversation very difficult for us.
Oh,
So many times we try to convince the family that we should tell the patients it's better. Even your communications with the patients will be better. Sometimes they agree, many times they don't. And we
yeah,
have to sort of try and juggle around that a lot.
yeah, yeah. So that's
Uh,
both about, is that both about diagnosis and prognosis? So
that's, that, that's correct.
families would expect to hear that news before the patients often.
Yeah, yeah. Most
Yeah,
of the times, many times, unless it's a very young patients, and sometimes it's very patients who, young patient who make their own decisions. Sometimes, yes, but majority of the times, families, and I think families do a lot of, support the patient a lot. Families sacrifice a lot for the patients, and that's the sort of the culture we are, that's here. So we need to kind of respect that.
absolutely. I mean, I think families are absolutely essential to caregiving, whether or not,
Mm,
professionals are around, aren't they? So
yeah.
that is absolutely critical that they feel involved and respected. It's not an uncommon tension. Certainly, we had a similar situations in Malawi. Sometimes it felt like it was about asking families permission to ask patients
Mm,
if they wanted to know, rather than saying
yeah.
we're going to tell them. It's sort of, is there
Yeah,
anything they want to
absolutely.
know? And I mean, from your experience, how do you find it? Are patients open to hearing, or do they
Well,
prefer
there
it?
are there are patients, and I think that's probably on the increasing trend nowadays that patients would want to know, and then it's much easier to have that difficult conversations, and they accept, and things are so much easier to deal with when that happens. I think what I found is that people here are we are sort of not so open to sharing our emotions, and I think that's what makes it difficult. And families worry about that the loved ones will get depressed, will worry too much. But also there's this barrier of not sharing the emotions. So uh, if they find that you know both the patient and the family knows about this, I think it will be very difficult for them to converse. They don't know what to talk about, and I think that
Interesting.
that's probably one of the
Yes.
issues.
Yes. Yes, that's very interesting. I don't know a lot of details about the health system in Nepal, but again, maybe I shouldn't make comparisons with Malawi, but sometimes I think because families are not willing to maybe accept the diagnosis, they may hear it and then run somewhere else to another health provider to try to find out better news. Is that something that potentially would happen
Yes,
in
I think
Nepal? Or,
yeah, I think the most of the time they accept the diagnosis,
okay,
but they would not accept the sort of the prognosis that they wouldn't want to hear that there's nothing else to do.
yeah,
So they will find someone that will give them some other chemotherapies, second line, third line, and when that doesn't happen, then they'll go to other forms of Ayurveda or other alternative medicines, just trying to prolonging life seems to be very
sure.
important.
Yeah.
and sometimes understandably so. And I think there are also our physicians are also, uh, very reluctant to give up, So we start trying second line and third line, even when the patients are having very difficult time, both physically and sometimes financially. And I think that happens quite a lot, I think.
And it's hard in a way in palliative care because we want to care for people, don't we? We want to show that same
Yeah,
care. It's just that we're taking a different angle on that, isn't it? So,
yeah, absolutely.
but obviously, you've now done this for 25 years in Hospice Nepal. Do
Yeah.
you feel that people's attitudes are changing? Obviously, people accept care from Hospice Nepal. They don't say, "Oh, that's not for me," or do some people say that's not for me? How does that
No, I think
play?
it's changing. I think it's changing. Over 25 years, there's been a lot of change, and I think even when we started, the physicians most didn't know what palliative care was about. They hadn't heard of hospice, but now that's changed quite a lot. Now we're getting a lot of referrals for non-malignant disease as well. So things seems to be changing. Things seems to be changing everywhere. It's the same. I think it takes its time.
Do you think there's anything specific that makes a difference in terms of, is it the kind of relationships between doctors sort of trusting the palliative care providers, or is it people seeing what palliative care does, or is it just time or changing attitudes?
I think it's true. I think you're right when I think seeing what palliative care does. Especially in our institutions, we do make presentations from time to time and tell the stories. We have a grand round every week in our hospital, and most departments when they present is about the cases, the diagnosis, but when we present it's about stories of people's life, and I think you can see the changes. And in our institutions, we have started what we call medical humanities in our undergraduate nursing, undergraduate medicals, and we talk a lot about life, talk a lot about death and dying, and how we would want to die. I think makes a difference. Having worked in the education system for a long time now, starting the medical school, the nursing schools, and all that, I've found, I think globally, I think our health professional education system, there's something wrong in that. There's a lot of science, a lot of technology, but very little humanity and that about human connections. We don't talk about that at all. It's so disease-oriented teaching, and that leads onto a very disease-oriented practice. We learn the
Yes.
pathophysiology, what a disease does to a body, but we don't talk about what a disease does to a person's mind, the soul, the family. We don't talk about that, and I think that's important. We're trying to bring that approach. So with the humanities and all that, and integrating palliative, I also believe that palliative care really, really has a lot of can play a lot of role in health professional education system, changing the whole scenario, getting the humanity back into the education system. And I think that if we are able to do that globally, a lot of suffering could be avoided. A lot of unnecessary intervention at the time of dying can be
Yeah.
avoided, and I think that's true globally, really.
It's so critical, isn't it, that a focus on
Mm.
humanity and the broader aspects, and in a
Yeah,
way I guess science now, technology and new technology is taking us further and further
yeah,
away from that, AI being the latest example, and
that's
sort
correct.
of forcing us down channels where
Yeah,
technology is even dictating to us what matters, instead of
absolutely.
perhaps looking in front of our very eyes what matters, our own families, our own connections.
Yeah,
And yeah, the kind of the power of human connection is something which is free, isn't it? And yet we often
yeah,
don't value it because it's not
that's correct. Yeah,
modern or new. So that's really fascinating that you've been able to embed that in pattern and then wider in the system. In terms of the education system, is palliative care something which is part of standard training now, or does it vary quite considerably? I think there are many training institutions for
yeah,
healthcare professionals in Nepal. Would it vary quite a lot whether people have
yeah,
exposure to palliative
absolutely.
care or not?
It varies a lot. I think ours is the only institution where we've been able to integrate palliative care into the curriculum. We have been trying to talk to the councils, the education commissions who are responsible for the curriculum for the whole country to integrate palliative care into the curriculum, but we haven't been so successful yet. So it's really varied at the moment, unfortunately.
Yeah, it's a work in progress, isn't it? There are so many fronts that you have to push on.
First, education is one really important front where,
yeah,
if you embed palliative care, that also brings out the humanity and the communications, the connections. And I think palliative care can play a very important role in the education system.
Is it possible to be a palliative care specialist in Nepal, recognised by regulatory bodies or not?
Yes, now yes. So we've started this fellowship in palliative care, so they can now become palliative care specialists, and there are young people coming up to do that palliative care recently.
Yes. What background would people have to come from in Nepal to do the MD in palliative medicine?
It's not MD, it's a fellowship in palliative care.
Sorry, a
So
fellowship. Sorry. Yeah.
we require for them to do any of the postgraduate system like a MD or general practice.
Okay.
So once they have completed that, they can then do this 18 months fellowship.
So they do a postgraduate training and then fellowship after that, and then the regulatory bodies recognise that within Nepal to be a specialist. Is that quite recent, the recognition?
That's very recent. That's very recent.
Oh,
We started the
excellent.
fellowship only about 3 years ago.
Fantastic.
So that's very recent. But I think that brings hope, youngsters coming up to join palliative care and taking that as a profession is a very important step, I think.
Yeah, seeing the young people come through after 25 plus years in this area. It's nice, isn't it? Yeah. Can I ask you a little bit about the situation in terms of opioid medication, the availability and challenges for that?
We are fortunate that we now have morphine produced in our own country. So we have morphine tablet, long-acting, short-acting. We have morphine injections, and we have morphine syrup. We were able to start that in 2009. Before that, we were importing from India. Initially, when we started in the year 2000, we just had injection morphine. And then we imported oral morphine from India. So from 2009, we were able to produce in our own country. So from that time, the supply has been very good. Unfortunately, we do not have alternative opioids like oxycodone and hydromorphone. But even then, I think having morphine, is such a blessing.
Absolutely. And is that throughout the country? If people needed morphine, they would be able to get it, or
we have morphine in the institutions. So institutions can have morphine, and I think most large institutions usually have morphine supply. It is the morphine needs to be prescribed by someone with a medical degree. They need the council number to prescribe that, but it's still not very available everywhere. So there are still a lot of problems, especially in the rural areas. It's very difficult to get morphine. So when our patients in rural areas need morphine, we would register them as our community patients, and we would send morphine. Usually, there's someone, family member or some relative in Kathmandu. So then we would send them morphine through them.
you have ways to make it work for people in rural areas. Quite a few places in Nepal are difficult to get to for a variety of reasons, or take a long time. So I'm sure access to care in general, but certainly then access to pain medication and other things is going to be a challenge, isn't it? Yeah. Yeah. Do you think there are learnings that can come from Nepal for other settings? I mean, you mentioned the role of family and the importance of family and family support, and that's a real resource, isn't it, that other countries, perhaps high income countries, have less of, with the isolation that people experience here. But are there other things that you feel the rest of the world can learn from Nepal?
I think one of the things we've been doing is trying to bring palliative care to rural Nepal, and the context and the geographical terrain and the hilly region, the mountainous region, and even in the flat regions, the poverty and all that makes providing palliative care difficult. And for every country, the context is different. And I don't think you can import the Western system right into the in each country. So I think you have to work with what you have in the rural areas of our country. We have a very good primary healthcare system. There are rural healthcare workers embedded in the government system all over the country. And so we have been using the health workers who are working in the villages, train them in palliative care, and they visit patients' home, sometimes 2 hours away, sometimes 4 hours away, and go to
Are
patients'
these
home and
the
provide care.
female community health volunteers? Is that the right term?
Not female community health volunteers. There are female community health volunteers in Nepal. There are more than 50,000. But they are really overworked with all the other things that they have to do. But we have also what we call the mid-level health workers, like the health assistant nurse midwives, who are in the primary healthcare system. They work in the health post and primary health centers. So we have been training them. This is a 1 month training in palliative care, and then they are allowed by their system to go to patients' home and look after them. So this we have been
Impressive.
doing for the last almost 10 years, but we have sort of accelerated that in the last after COVID. We have we have now covered the whole of Bagmati province. We have 7 provinces in Nepal, so we have almost covered one province, the Bagmati province, and we now have about 250 healthcare workers who visit patients' home. And in this fiscal year, they have made about 6,000 visits and looking after about 1,100 patients. And what we have found is that more than about 70% of our patients are patients with non-malignant conditions.
Mm.
And only about 30% are cancers. And so I think the opioid availability itself should not be we shouldn't see that as a barrier to start palliative care. Majority of the patients actually don't need opioids. They need
Yes.
care. There are a lot of patients in the villages with, they have strokes. They come to the cities, then they are sent back home, and they develop bed sores. And there's no support. So I think
Yes.
that's so important. Just providing
Yes.
that care.
Yes. Sometimes the availability of morphine is used as a proxy measure, isn't it, for
Yeah,
palliative care services? But as you say, that may in fact limit the way that we see palliative care provision because not everybody needs morphine.
yeah, absolutely.
As much as some people really do, other people have other priorities.
Yeah,
It is important to remember that, isn't it?
yeah,
And
absolutely. I think that's true. Some people really need that morphine and opioids.
yeah,
But majority of our patients, the morphine is not the requirement. The care
yeah,
that they need, that you know.
yeah.
We had a patient. This was a patient in a very remote area of Bagmati province, in the hilly terrain. He was a 52-year-old. He had brain tumor, and he came to Kathmandu. Then he was sent back home because nothing else could be done. And he was vomiting. He had severe headache. And one of our health visitors, this young girl, she had to walk about almost 2 hours to reach his home. And he required dexamethasone and metoclopramide. And fortunately, there in the health post they had injection dexamethasone and injection metoclopramide, and they had IV cannulas. They didn't have butterflies to put subcutaneous.
Yeah.
So this girl put an IV cannula, taught the patient's son to give dexamethasone and metoclopramide every day, and a week later his headache was gone, his vomiting had stopped, and he lived for 2.5 months. and he was
Wow.
having this IV
Yeah.
steroid and metoclopramide, and he was feeding his chickens and
Fantastic. So
trying to
it's
work with what we have, really.
exactly, and adapt. I think it's interesting that you started 25 years ago with Hospice Nepal as a small but very significant institution. And then from that, so much other work has developed into institutions, into the education system, into the community. So much has kind of rolled out from that. And as you say, using the health workers on the ground. It's interesting that you raise the issue of the heavy burden on some community workers, and I think that's being noted, isn't it? Sort of globally, that everything's being pushed to community health workers who already do a lot.
Yeah,
So it's interesting that you have identified and you have that kind of mid-level cadre who are so effective at adaptation is really important to
yeah.
learn from.
I think you just work with what we have. But I think there's a lot of hope now. I think with the young people coming up and taking interest in palliative care. As I said before, I think palliative care can play a lot of role in the health professional education system. We have to do that globally. Uh, and I think my message would be to work with what you have and to not see the inability of opioids as a barrier to starting palliative care and to progress that. And I think once you start, then opioids will, it's much easier to have those things later on. Uh, the future is, I think, quite bright. I think,
Yeah.
getting palliative across globally, and I think the need is everywhere.
And if you don't mind me asking a question, 25 years ago or so, you started Hospice Nepal and you engaged in lots of different healthcare, trauma care, ambulance, various answering various kind of needs in Nepal. What keeps you going? Where do you get your source of inspiration? Have you always been like this since a child, kind of building things and developing things, or how do you keep yourself
No,
going?
I think, the blessings that you get from patients, I think that basically what keeps you going. And the love sometimes, the connections that you have with the patients, which if I had just done surgery, I would have probably missed that. I find a lot of inspiration from that. Seeing patients and their families and their suffering, their pain, but also their resilience and the sacrifice that the families make for the patients and their love. I think that to be able to be part of that journey and to see that from very near, I think that's basically enriched my life so much. And that basically keeps me going.
For sure, that's real deep job satisfaction.
Absolutely.
Been a blessing to you, but then you've used it to bless others. So I'm really thankful for that. Yeah, that's great.
Absolutely.
Palliative care matters because palliative care isn't just a specialty, it's something we all do. Subscribe wherever you get your podcasts.